here are the three types of surgical guides. So you've got a tooth-borne guide, a soft tissue guide, and a bone-supported guide. So tooth-borne guide, think about what we're doing every day with the simple single surgical guides. You're snapping a guide onto teeth. A soft tissue supported guide is actually resting on the soft tissue. So an edentulous patient, and it's like a denture, right? You think about a denture sits over the soft tissue and it just rests there. Well, you can build guides like that, right? You could duplicate a denture. You could turn a denture into a surgical guide where it's resting on soft tissue. And then the third is bone-supported guide, where a guide is actually literally laying on a jaw. So you have them fully flapped open. That would be like what a bone reduction guide is. So a bone reduction guide would actually be pinned up against the jaw, and it's actually resting on the jaw. So if we talk about these three, this is the one that I want to teach because it's the simplest. Because you guys are already doing tooth-supported guides for single teeth. So if we can just build upon that and plan full arch cases with teeth being our supports, it's going to be a lot simpler. They're the most stable. So soft tissue's unstable. It's bouncy. It's not going to hold your guide perfectly in place. Whereas if it's snapped onto teeth, it's the most accurate thing we have. Our intraoral scanners are super accurate. It's going to make guides that are really tight, really snap in. And so if we can do that, we want to try to do that. And then bone-supported guides are the most complex. They're going to require pins because you're going to be pinning it into the bone. This is what you do for bone reduction guide, but it's the most complex to plan, and then it requires this thing called bone segmentation, which I'll talk about in a second. But this is what I want to teach. So you go, okay, how do I do a tooth-supported guide if I'm pulling out all their teeth and putting in a full arch of implants? So this is kind of where we've distilled down the workflow, and it's really as simple as what's called selective tooth extraction. So let's say they've got all 14 teeth in there, but they need them all pulled out and they need implants to go in. How can I put those implants where I want them and then leave a handful of teeth in their mouth to support that guide? So the case that we're going to do, for Latoya's case, she's got all 14 teeth. So think about, I'm going to leave the second molars. I'm going to leave the canines, because typically we're not putting implants in the canine sockets because it's a big socket with a thin buccal plate. It's just not a good place for an immediate implant usually, or generally you're not putting them in there. But what if I pulled out all their teeth other than just the canines and the second molars, because usually you're not putting an implant in the second molar area. And now I pulled out everything in between those teeth. And then my guide just slips on to those 4 teeth. You got second molars in the back as a distal anchor. You got big canines as a front anchor. Now this thing just clicks onto the 4 teeth, and now you just place your implants in between. So awesome way to do it. That has been by far my favorite way to do full guided cases, just selective tooth extraction. So you got to digitally extract those in between teeth and then build your guide, but pretty simple. It's not really any different than what we're doing already for immediate implants. It's just doing multiple of them. And then implants go in, take your guide off, pull the last 4 teeth, and you're done. And the implants are all in. And then you think, okay, am I reducing bone or am I not? And then you're finishing up that case in the surgical phase. So really, really good way to do it, to use teeth as your supports. It's fast to plan, simple to do, very stable, and I mean, that's how I'm going to recommend starting for a while, and that's how we're trying to plan every case. How can we keep a couple teeth in there? Sometimes it's a second bicuspid and a canine, and you're leaving those 4 teeth, and then you're building your implants around that. If they were edentulous and they came in, they had a denture, and they want implants placed for an overdenture, implants placed for a fixed restoration, you can just scan that denture, convert it into a surgical guide. We kind of did that before in one of our courses, but it's soft tissue supported. Maybe you just hold it with your, hold the guide and you do your, drill your implants. Maybe you put it on and you put some pins in there to support it. Lots of different ways to do that. But a lot of these patients, they have teeth. They have hopeless dentition. It's going to be more common. Bone-supported guides. Yeah. Yeah, please.
So you were talking about Latoya having more advanced perio. So I would just guess that canines typically will probably have enough bone to support the guide.
Yep.
Do you ever run into problems with second or first molars where the perio there's mobility issues, and so your guide is is it still better even if it's moving a little bit than the soft tissue guide?
Yeah, that's a really good question. I think so, because I think you could still use those teeth, to a class 1, class 2 mobility, no problem. Because, when you fixate and 4 teeth get locked in, yeah, absolutely. I still think it's better. And I wouldn't be too concerned about that. If it was just swimming, then yeah, you can't obviously use that. But for most of the time, little mobility is not gonna do too much.
So you definitely check mobility though before, along with your smile and all that.
Yeah.
Checked or not, or
yeah.
Has that ever kind of burned you on that?
So I haven't got burned on that at all with mobility, because generally those floaters, soft tissue floaters, you're just gonna know because it just came up in the exam or when you're planning the case. I mean, you can see a floater on an X-ray, and you just know, hey, I'm not going to anchor onto that thing. But pretty much everything else, as long as it's got some bone around it, it's going to be enough. Okay. So just, those crazy floaters, yeah, I pass on those. But everything else, you'll be fine. Because when it locks on, these guides are pretty tight. It just kind of holds everything together.
And if you have 3 other teeth or something that are solid,
yeah,
it'll kind of just
yeah,
yeah, a better term, right?
Yeah. It would be depressibility would probably be the no-no, depressible teeth, but that's just not too.
You see a big old periodontal lesion on that X-ray.
Yeah, yeah, it's gonna stand out like an elephant.
You see it too if you're just there with them moving around with their tongue, right?
Yeah.
It's a no-go.
Yeah, it's a no-go. But yeah, that's a good question.
On that case, say for where you selectively extract, place on your implants, you're placing your implants super deep in that bone, and you're just kind of eyeballing a 3 millimeter reduction of bone after that.
Exactly.
Or whatever your bone reduction is based on your plan.
Exactly. Yep, that's exactly right. Because
until you're just measuring with a probe where you can see your implant platform is now a millimeter below the bone and you're good.
Exactly. Yep. Yep. Okay. That's exactly right. And I even did a couple early on, I was a little bit leery about kind of just, eyeballing the reduction to my implants. And I was like, okay, I'm going to make a 2-supported bone reduction guide that shows me where I need to reduce the bone. And I found out, I'm like, this isn't really helpful. You could see your implant, it's just, it's down there, and you're just taking the bone down until, okay, good. It's at the right subcrustal level. And that it's really not difficult. So I just kind of figured, hey, I don't quite need to make these bone reduction guides as much. It just kind of ended up being just a waste of time. And just like we talked about before, simple. And now you can do these cases between patients because selectively extract some teeth, digitally place the implants, go build a guide on that. It's more complex than that, but not really. It's just taking all the little surgical guide things that we talked about and just doing it. And the other thing is like with Latoya's case, she had some perio, and my restoration isn't even got 15 millimeters of thickness. And this is her hybrid. You guys are going to design her case, and you'll see in the back, there's not that much. We're getting to the point where that minimum reduction is becoming a little bit less because materials are getting better. Because the 15 to 18 millimeter reduction was built on an acrylic hybrid model.
Zirconia too, right?
Yeah, and pure zirconia only, the brittleness of those. So, and when we talk about, the temporary restorations and then the bulletproof restoration, you're just needing less and less, which is cool because, you can tackle more cases, reduce less bone, keep things more simple. So Latoya's is more in that 12 to 15, 12 in the back, kind of 15 more in the front, and you'll see that in her case, and it's great, it's fine. So, and her case just didn't need that much bone reduction. You can then do just more like a minimal flap after you're placed your implants. You just tease it back and just say, okay, that bone's too high, and just kind of take it down instead of a big old crazy case where you're hacking everything. You can be a little bit more conservative, which is nice.
Yeah, so Matt, on the soft tissue guides, I'm
Yeah.
0-3 since our last meeting.
Like, you printed them?
I did the denture, and every time I go in, I'm
Yeah.
always buckle.
Yeah.
Like
Yeah.
I'm slipping to the buckle.
Yeah.
And so I'll just let my flap and freehand there.
So did you try to punch?
Yeah.
Yeah. So that's exactly right. Is those are very, very tough to do because usually you've got a knife edge or a very, very pointed ridge. That's the same with our single tooth. So don't try entering the ridge at a knife edge approach, whether it's a single tooth or it's a soft tissue guide. You've got to get that flattened and that in a solid platform. And I've been doing a lot more guides.
Too, James, quite a few.
Yeah.
Where you can't just trust the guide because the guide will push you. You can go, you go buckle or lingual really. If it's a thin ridge, you almost have to kind of
You got to like
start it almost.
like a pilot punch.
Comes with that, the little bone flattener.
Yep.
You know, the blue sky kit.
Yep.
You can, you can take that down first and kind of flatten real
Well,
quick.
and then once, so I've
Yeah,
tried
but if
to
it's
lay
so
the flap,
thin, it
and then
doesn't
all
really
of a
help.
sudden that duplicate denture really doesn't fit over.
Yeah,
It's
that-
like it's sitting on tissue. It's
hard.
folded over.
When they're real thin, I've struggled with that too. I've had to really eyeball and make sure
Are
I'm
you
getting
have
the
sleeves in that, or do you just have a window in the denture and you're just
Yeah.
no window?
Let me see here. So let's see here. So this is like,
Otherwise, what, you have to flap everything back and do a bone guide.
Then you have to do the full bed, right? I mean, that's what I was gonna ask Matt.
so here's what I would do. This is how I would do those cases going forward. I would duplicate the denture, but add 3 pins, dead center, and then kind of the left and kind of the right. Put it on the soft tissue, drill 3 pins, 3 pinholes, okay? Then take the denture off. Don't put the pins in yet. I would drill 3 pinholes, take the denture off. I would do a lingual incision all the way across the ridge, okay? And then I would pull the flap back. And then either kind of flatten the ridge or do a starter hole, like a pilot hole with a round burr. Because once you have a started hole, these guides are really accurate, but it's that first drill that you get screwed up on. Because if you try to enter a ridge with a drill, and that's with or without a guide, if you just take a drill and try to run down a ridge, you slip off. You have to either have a big flat base or a little starter hole. So like what I do is a lot of times is I have that guide on, and I'll take a long round burr and I'll just go through my guide hole and I can see the ridge, and I'll just kind of peck a starter hole. And then now you can go with your drills, and they're going to find that hole and just go straight through, and it's going to be guided well. But it's not tight enough to hold it against a sharp ridge. So, and the other reason I would do that too is because exactly like this. So, okay, here's a soft tissue guide. Looks great, right? Like, looks cool. Here's the. So, you take the guide off and you're like, all right, like, it's punched through. Hopefully I'm like in the bone, like you were saying. And that this isn't, I found this case online and I wanted to show it. But then the other aspect is like, because you punch through, like look where your multi-units are now with your mucogingival junction. Here, 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 here. And so you end up just like with no keratinized tissue on the facial of those. So not only are they prone to recession, but they're also kind of ugly a lot of times because you build that restoration, you pull it back, and you can see the metal multi-unit abutment. We see those cases with hybrids, and it's like, fine, whatever, but it's prettier when you don't see that silver. And all it would have taken on this case for this person is just make an incision right here, pull that back, then go put your guide back on, and then put the pins in, because you've already drilled the holes. And then now you're supported on the pallet, and you're supported with 3 pins. Your flap is back, and then you did your starter holes, and now you could go guided and get a really nice result. Does that help? So I think you got to incorporate a flap, and you got to incorporate some sort of like flattening or starter hole for your drill. I think those are the.
Really thin ridge. I mean,
Yeah.
I do those, 3 O's in a ridge where you can seriously see paper thin both sides. Where I can see both sides.
Yeah.
That's probably not a good guidance case in my.
Yeah.
If it's so thin, you can't just trust the guide.
Yeah.
You have to almost freehand that.
Yeah.
You have to be really careful in those cases.
I totally agree. I totally agree.
A slide or two of applications with thin bridges and deflection and everything too. So
Nice.
Yeah, those aren't easy.
Yeah.
The guides that takes
Yep.
your visual ability away.
Yep. And then the other thing is, okay, that flat drill, fine, but I found myself like shying away from it a lot because the flat drill is a 5 millimeter drill that's going, if you take it to depth at your offset, it's going to go to the implant platform. So now, if we're placing subcrestal implants and you're drilling a 5 millimeter osteotomy, you've like blown that ridge out. And how many ridges are big enough to support a 5 millimeter wide osteotomy and still have good bone on both sides? Like, it's not that often. So I don't love that one.
Even for like the top 1 millimeter, like just a chip, I just
Yep.
touch the ridge real quick.
That's fine. I do that too. Yep, just to kind of, where you're not taking it to depth, but just kind of poking.
Okay,
And
no, not that. Just like that top millimeter, just kind of flatten it.
Yep.
And then I go in with my 2.0 and
Yep,
start.
yep, that's fine too.
Same as, I guess, a round burr. That's probably even better than pitch down in.
Yeah, the round burr, it's kind of case by case, but if you can do a little round burr, like now you don't even have to think about it because it's just going to find that hole. It's just going to go straight into that hole, and the case will go well.